All right, so this morning we're going to really do just kind of the, super starting point of basic, kind of BLS level airway management. But then, I mean, even if you're in paramedic school, if you are a paramedic, everything still for us functions and works from BLS to ALS, right? When I was prepping for National Registry for Paramedic, we had a guy that came in and talked to us about the test and how he prepared for it and everything. And he reminded us that you get that little whiteboard when you go take the test at the testing center. And it's, you can take notes on it during the exam, use it to do a math problem or something like that. And he said, this was on the paramedic test, he said the only thing he wrote down was BLS before ALS, right? Because that's how much of an emphasis they put on we start from the very beginning, and then as things happen, we can work ourselves to more and more invasive interventions, right? But we're always going to start BLS before ALS, or least invasive to most invasive, right? So this is really just going to be a good starting point, a good review maybe for you, or looking ahead, depending on where you're at in the program, on how we really start that process of airway management. Really, once we've made the decision that we need to do something for the airway, then what's really the sequence of steps that we're going to go through and do it. All right, so first step, right, or really the first 4 steps, when we look at airway management, is really broken into 4 distinct things. Right. The first one is that we actually have to obviously open the airway. Right. Now, if our person is talking to us, like I'm sitting here talking to you, right? If I'm your patient and you walk on scene and I'm sitting here just talking, a million miles a minute, saying a bunch of stuff, that tells you that my airway is open and that it's clear as well, which is going to be step 2 here in a second. Right. So if the person's talking and communicating to you, that airway is open, or what we say is patent, right? Patent. So step number 1, open the airway. And we're going to walk our way through kind of a few different things that we can do for each of these steps. The next one is then clearing the airway. Right. So depending on the patient, whether they're, unconscious on the ground or whether they're alert and talking to you, right, we may need to clear the airway. And we'll talk through about how some of this stuff will actually get worded in terms of like test questions and National Registry questions, right? So we have to open up the airway. And when we open it up, we're going to take a look inside and we're going to make the decision of any sort of clearing of the airway, right? Is there anything that indicates to us the need for suctioning, right? That's really where we're going with that clear of the airway. Then we have to assess the quality of breathing, right? Because airway management is hinged a little bit also based off of the breathing assessment. Right? So I know we have our airway, breathing, and circulation, but 100% of the airway decisions don't just get made in airway, right? It's really that airway breathing combined, because somebody could have an open and clear airway, but not be breathing. Or somebody could have an open airway that, is bleeding into their mouth or has some vomit in their mouth, but they're still breathing, right? So the airway and the breathing is separate, but some of the stuff that we do is going to be kind of based off of what both of those aspects are actually doing, right? So we need to assess the breathing. And then the last step is then make the decision on any sort of intervention that we're going to do, right? So we have to open, clear, assess, and intervene. Open and clear the airway, assess the breathing, and then make our intervention decision. So opening the airway is really just step number 1, a pure, just simple positioning change, right? Just a simple position change, right? So one of the kind of key things that, all EMS books will emphasize at some point or another is this one here, that the tongue is the number 1 airway obstruction, right? So these 2, this head tilt, chin lift, this jaw thrust maneuver that we have are really designed to just try to lift the tongue out of the back of the throat, right? Because as that brain starts shutting down because we're going into shock, or, you know, we're bleeding out, whatever that situation might be, right? If we start going altered because our brain's not able to function as well, right? When we go altered and things start shutting down, muscles start relaxing. Right? And we have the muscles that hold up our tongue in our airway, those muscles relax. And so that tongue relaxes and it's just going to drop back into the back of the throat and going to block the airway. And so if you do just a head tilt chin lift, or if we do a jaw thrust, both of those just lift the tongue out of the back of the throat. Both of those just lift the tongue out of the back of the throat, because that's the assumption, right? Tongue is the #1 airway obstruction. So let's deal with that one first. And then once we deal with that one, then we can take a look inside. Hey, is there vomit in there? Do we need to suction? Do we, you know, is there anything else that we need to do? Right, but first things first, simple positioning change, right? Lift the tongue up out of the back of the throat. Right? And again, this is obviously something that we're only going to do if that patient is semi-conscious, unconscious, unresponsive on the ground, is we need to evaluate, hey, are they protecting their own airway? You know, let me, you know, do a head tilt chin lift and take a look. If that person is sitting there talking to you, well, they're protecting their airway. You know, we don't need to, you know, have that person sitting up on the couch doing a head tilt chin lift or anything like that. All right. So the two options, head tilt chin lift and jaw thrust. And the head tilt chin lift is when there's no suspected trauma, specifically like spinal cord trauma, right? Because when we do that head tilt chin lift, right, that's going to put a lot of movement and a lot of pressure high up on that cervical spine, right? So we're only going to do that head tilt chin lift if we feel pretty dang confident that there wasn't any sort of trauma that this person sustained. If there is trauma, known or suspected, then we'll do that jaw thrust. And that's where you just kind of push on the back of the jaw, and it just pushes that lower jaw forward. Right? And so it doesn't, you know, take any sort of head manipulation. You're just pushing that jaw forward, right? Jaw thrust, right? You're thrusting that jaw forward. So that's just in those known or suspected trauma patients. Or, I mean, to be perfectly honest and safe and cover yourself, if you just have no idea yet what happened, do the jaw thrust. We can always change how we position the airway if we find out, oh, this isn't, you know, this isn't a trauma at all. This is a drug overdose. Right? So it's a little bit easier to open the airway with the head tilt chin lift, or at least to keep it open, because otherwise with the jaw thrust, you have to sit there holding it open until you do something else. So if it's known, suspected, or if you really have no idea yet, do that jaw thrust maneuver. Right? Because we can always go to the more manipulating head tilt chin lift, right? Or if you do that head tilt chin lift and then you find out it was trauma, you're like, ah, crap, like, let me put that back, right? You can't do that, right? So go on the more cautious approach initially with the jaw thrust until you know for a fact that there was no trauma. And then you can switch to that head tilt chin lift. Or if something in a, you know, multiple choice question scenario says, you know, there was no trauma, this is what happened, then you can go straight to your head tilt chin lift and you'll be good there. All right. Step number 2, we said, was clearing the airway. Right? So we had to open the airway, which is the positioning change. And now we have to clear the airway. Right? Now we only clear the airway, and this is a good like registry test taking strategy type thing. We only clear the airway, we only suction the airway if they tell us there's something that needs to be suctioned. Right? We don't just on our own say, well, this person must have something in their airway. We don't start making assumptions about a scenario question. We don't add stuff to it that's not there. So if they say there's gurgling respirations, that's telling us they've got some fluid in their airway that we need to clear out. Or they tell us, you see blood in the airway, you see vomit in the airway, right? There has to be something kind of explicit telling us there's something in the airway, or the gurgling that we hear in the airway. Okay. Back to that tongue is the #1 airway obstruction. If the descriptor of that breathing is snoring respirations or sonorous respirations, that's typically just the tongue blocking the airway. So positioning change will deal with that, no problem. If they say there's gurgling in the airway or gurgling respirations, that's the person's breathing. They're trying to move air through, whatever sort of fluid, blood, vomit that they have in their airway. Right, so we need to suction. Right? Now, first things first is most of us are not just walking on scene with our suction unit saying, all right, let's do this. We're ready to go. Who knows what we're going to see, right? We're carrying all of our equipment, right? But we don't have suction and everything set up, ready to go, right? So if they say the patient vomits, then there's vomit in their airway. Really, step #1 on clearing the airway would be to roll that person onto their side and let gravity help kind of drain out any of that stuff. Because you don't want to have that patient on the ground, right, supine in front of you, and they vomit in their airway, and you look at them and say, okay, 1 second, let me go get my stuff. And then you come back, all right, now we'll suction that out, right? You want to do something right away. Right, because we have to fix that problem right away, right? Blood, vomit, something like that in the airway is a life threat. So we need to deal with it right away. And we're not sitting there ready to go, waiting for somebody to vomit, having our suction ready. So let's do just a log roll, get that person onto their side first while somebody else is getting our suction set up, right? That's a very good typical style test question that kind of highlights the point that I made at the start, which is we work our way from least invasive to most invasive. Right? Rolling somebody on their side is less invasive than shoving that suction catheter further back in their mouth. Right? So roll the person on their side, let gravity help just drain whatever fluid is out while you get your suction ready to go. Right? So there's a lot of different type of suctions, right? Suction canisters that are battery operated, power operated, like that yellow one there looks like it's plugged in with a power cord. You have wall mounted ones in the hospital. You have wall mounted ones in the back of the ambulance. And then you have other little just handheld, almost like a spray bottle that just, suctions as you press on that trigger part. So a lot of different ones, right? One of the, kind of little textbook question, kind of Jeopardy question, gee whiz information, is they will tell you in your books that the suction canisters need to be able to suction with at least more than 300. And on the pressure side, that mmHg is millimeters of mercury. It's how they measure pressure, one of the ways that they measure pressure. So suction canisters need to suction with enough pressure of more than 300. Pure just random Jeopardy question there for you today. All right, so with the suctioning, once we've done the log roll, trying to get our patient to, or have gravity help us out clearing their airway, then we make that decision of, okay, let's suction. There's really two kind of typical styles. When you have your suction tubing, right, and just kind of plug them right on there. But we have these kind of flexible suction catheters that are, a little bit thinner, and they'll have some sort of kind of port there for you to cover up, right? And what we have to remember is all of our different, suction tips have a little port for us to cover. And once we actually cover that up, that's when the suction will start out the end. Otherwise, when that machine is running, it'll be sucking air through here, not through that tip that we're actually going to use to suction the patient's airway. And so once we cover that up, that's when we can actually test and see, hey, yep, that suction's working for sure. Okay. So these flexible suction catheters work well if a patient's intubated and you or the medic are going to suction down the endotracheal tube, right? Because it's a lot more flexible, it can move and bend with it. More standardly is we'll use these rigid tip catheters. Again, same thing, this one's a little bit harder to see, but there's a little port right there for it, that once you cover it up, that's when suction will actually start on the end. And you can kind of suction against your gloved hand just to check it out and feel it. All right, but these rigid tips are called tonsil tip catheters or Yonkauer. Let me try to write that down. All right, tonsil tip or Yonkauer. I think that spelling is right. So that's a more standard one, a little bit larger of an opening than the little flexible catheter ones. So it works better for thicker secretions, maybe some vomit and stuff like that. Sometimes it'll get clogged and you may have to try to, loosen something afterwards as you're trying to suction the airway. But these rigid tip, tonsil tip catheters, these hard plastic ones, right? They don't really bend compared to the really flexible suction catheters. And so when you're going to suction, kind of regardless of what type it is that you're using, you're only going to insert the suction catheter as far as you can see, right? So we're not going to kind of try to bury it deep down into that person, right? We're only going to suction as far as we can see, right? So we're not going to make that curve past the base of the tongue, right? So we're really suctioning back to the base of the tongue. And so they'll say insert it without suction, which even though the machine can be on, without suction is just we haven't covered up that hole yet. So insert it without suction on, then start the suction, and in a circular motion on the way out, you can suction it out. And the time intervals are based on, are we talking about an adult, a child, or an infant? Adults, they will say suction for no more than 15 seconds on the way out. So again, same thing, we can insert, suction for 15 seconds on the way out. We can't keep going longer than 15 seconds because if their airway has been that full of fluid, blood, vomit, whatever it is, they're probably not breathing very well, if at all. And so they might not be oxygenating their blood. So we can't just sit there and suction indefinitely because the patient's not getting any oxygen, right? So we had a suction for 15 seconds, and then we can start, bagging the patient, which we'll talk about, so we can get some oxygen into the patient, and then we can go back to suctioning if we need to, if there's still blood, still vomit, still something happening, right? And what they'll say, right, it's a very kind of book answer, is they'll say suction for 15 seconds, and then if you need to, you can go back and you can bag the patient for 2 minutes before we'll go back and we'll suction for 15 seconds again, right? So we keep alternating 15 seconds, 2 minutes of ventilations, 15 seconds of suction, and 2 minutes of ventilation. So 15 seconds is for an adult, right? Kids and infants, their metabolism is working a lot faster. They're using their oxygen in their body much more quickly. So we can't suction for as long with children and infants. So it goes 15, 10, 5. A child will suction for no more than 10 seconds. An infant will suction for no more than 5 seconds. Again, same thing, we can use the same suction catheters, regardless of infant, child, adult. We're only going to insert as far as we can see without suction. Start suctioning, and then usually they'll say like a circular motion for no more than 5, 10, or 15, just depending on our age range, 5, 10, or 15 seconds on the way out. And then we'll go to our next step, which is, assessing the breathing, starting to ventilate our patient or whatever it might be. So a couple good tips there on clearing the airway with suction. 15, 10, and 5 seconds, super critical. knowledge point that you have, that one. And then certainly the concept or the idea of log rolling a patient when they vomit to help gravity just kind of help to drain some of that stuff out while we get our suction ready to go. Right? Perfect. All right, so airway adjuncts, right, is really with the idea that, you know, we don't feel that this patient can maintain and protect their own airway, right? Maybe we had to suction, right? And now we've done our head tilt chin lift or our jaw thrust to help get the tongue out of the back of the throat and to help open everything up. And now we've said, you know what, I don't feel like this patient can really protect their own airway and maintain it that well. So one of the ones that we will try is one of these little OPAs, or oropharyngeal airways, right? O-P-A, the OPA. So oropharyngeal airways, right? And they're curved like that to really curve with the tongue, right? Because we're trying to get the tip of that just past the base of the tongue. And it's going to help keep that tongue from collapsing down into the back of the throat. So it's only for unresponsive patients without a gag reflex. One of the ways you can figure out the patient has a gag reflex is put that in. If they start gagging on it, they have a gag reflex. Right? Another one that our book will talk about is if the person is there and they appear unconscious and their eyes are closed, and you just very gently go up and brush across their eyelash. Right? If there's any sort of kind of blinking twitchingness that's happening there when you rub on their eyelash, then they probably still have a gag reflex. Right? Not guaranteed, but probably. So that's a little test. But otherwise, when you put that OPA in, if they start gagging on it, then immediately take it out. You know they have a gag reflex. So really only unresponsive patients. If they're semi-conscious, they probably have a gag reflex, don't even bother. Right? So it's really, you know, what appears to be a fully unconscious, unresponsive patient. And we say, okay, they probably don't have a gag reflex. Let's insert an OPA and find out. Another one is anytime we're ventilating a patient with a BVM, we should really have some sort of adjunct in place. Ideally, the OPA on the BLS side before we make a change over to a more advanced airway, right? If you got a medic with you or something. So we've really got to start with an OPA most cases, right? Unless, again, the patient is semi-conscious or something is telling us that they still have a gag reflex happening. So measurement of the OPA, right? It's going in the mouth to the back of the throat. So that we'll measure it from the corner of the mouth, right, to, most books will say, to your earlobe, right? So corner of mouth to earlobe is the proper measurement, right? And they have all the way down, you know, to little teeny tiny ones for an infant, and they have, you know, full size adult ones. Now, step is, right, when we go to insert it, we're going to insert it sideways, and we're going to rotate 90 degrees, right? So we're going to come into the mouth sideways, and then we're going to rotate past the base of the tongue, right? That's what it'll actually be. So insert it sideways, rotate 90 degrees. Right? We used to insert it completely upside down and then rotate it 180. But what they found was that rotation would damage the roof of patients' mouths, right? Would damage that hard and soft palate up there. So they said, okay, instead of going upside down and rotating it over, let's just go sideways and rotate 90 degrees. Okay? And so the little kind of phalange part there should, you know, rest on the lips, more or less. And the end of that is going to be right at the base of the tongue, just helping to protect that, you know, kind of pathway there for patients to be able to continue to be ventilated, right? And to not have that tongue drop back into the back of the throat. Right, so really once you get an adjunct in place, you start to feel a little bit better about maybe letting go of your head tilt chin lift or your jaw thrust, right? Because now we've got something else assisting us to keep the tongue out of the back of the throat. So those are OPAs. If you can't do an OPA for whatever reason, another option is NPAs. NPAs, which are nasopharyngeal airways. Look like these, right? A little bendable, flexible tube. Right? The OPAs are solid plastic, and so they're not going to bend at all. But the NPAs, right, those are real bendable, right? Typically green little tubes in a lot of places. These are for your semi-conscious patients or unconscious patients, but they do have a gag reflex, right? So we can't, shove that into the back of their throat because they have a gag reflex, and it's going to make them vomit on us. And then we're going to have to suction them again because they vomited, right? So if they do have a gag reflex, right, doing one of these NPAs, right, which go through the nose, that's naso, right? Naso is nose, oro was mouth, right? Pharynx, right? Pharyngeal is the pharynx, that's in the back of your throat. So an oropharyngeal is through the mouth to the pharynx, through the mouth to the back of the throat. Nasopharyngeal is through the nose to the back of your throat. So you're going to put that tube up through their nose, and then the tip of that is going to rest just right back there at the base of the tongue, right? Just right back at the base of the tongue. Okay? So semi-conscious, unconscious patients with a gag reflex or a patient not tolerating an OPA for whatever reason are really the kind of indications that we have for using an NPA. Right? One of the kind of few things that are on the list of a contraindication for when we won't utilize an NPA and insert this through the nose or anything through the nose is any sort of head or face trauma, right? And the concern is if they've sustained any sort of trauma to the face, they may have skull fractures up there. And when we insert that through the nose, it could actually puncture into the cranial vault. And now we're pushing that up into the brain, right, because of the concern for those skull fractures. Right, so any sort of head face trauma, right, the NPAs through the nose are going to be contraindicated. All right, so we won't do them. All right, measurement, pretty similar to the OPAs. An OPA went through the mouth, so it was from the corner of the mouth to the earlobe. NPAs go through the nose, so let's do the tip of the nose to the earlobe, right? Tip of the nose to the earlobe. Right? That's the measurement there. You'll probably need to lubricate the NPA, so you'll actually be able to get it through. And then they'll tell you to insert it with the bevel towards the septum. Right? And the bevel, if you look up close to it, you can see this side is cut at an angle. Right? That side is nice and rounded. That side is cut at an angle. That's the bevel. Right? That's the bevel, and the septum is the middle of your nose. Right, the split between your right nostril and your left nostril. So the bevel towards the septum, right, is how we'll insert it. And then we'll just feed it all the way straight back. And then when we come along to ventilate somebody, and we're using that pocket mask that goes over the mouth and the nose, right? If they have that kind of coming out their nose, it's just going to help be able to deliver oxygen past the base of the tongue. All right, so question popped through. It's a strange question, but I know some people that have had their nose completely removed and it's just kind of like a hole. If that person had an airway issue and had a gag reflex, what would you do instead? So if they don't have a nose, then I would say it kind of depends, right? It would depend on what I actually see when I'm there. Do they still have, two nostrils that could potentially be inserted through? Then you might be able to still do it. If not, and they're not tolerating an OPA, and it really is the same as that head injured patient, right? If they're not tolerating the OPA, but then the NPA was contraindicated because of the head trauma, then we will try to just ventilate and bag that person without, an OPA or an NPA in place, we'll just do our best on the BLS side without it. If you call for ALS, right, then we've got a few other options, right? We can use some medications to sedate and paralyze the patient so that we can intubate them and bypass that gag reflex. Right, so on the ALS side, we have a few more options that are advanced, but if they don't take an OPA and an NPA is contraindicated, or we can't use it because they don't have a nose or something like that, then we'll just try to ventilate without an OPA or an NPA. That's another question is, do you do one or one in both nostrils? Typically just one, right? If we can ventilate the oxygen through the one tube, just fine, right? Just fine. So we'll just put one in. We don't need one in both nostrils. All right. Cool. So OPAs, NPAs, measurement, mouth, corner of the mouth to the earlobe, or tip of the nose to the earlobe, and add in, you're remembering that any sort of head or face trauma is a contraindication for the nasopharyngeal airways, the NPAs. All right, so oxygen delivery options, oxygen delivery options. And it starts to get into the breathing assessment part when we said first step is open the airway and then clear the airway and then assess breathing, right? The assessing breathing is, really figuring out how are they doing on their own, and that's going to guide what I'm going to do in terms of delivering oxygen. Right, so some of the terms of kind of the severity progression that we use is respiratory distress, respiratory failure, or respiratory arrest. And a lot of people will confuse failure and arrest. So let's work our way through kind of from bad to worse. Right? So respiratory distress is just some sort of difficulty breathing. Right? They're breathing still, but they're having some trouble, but they're still breathing okay. Like they could stay with that level of difficulty breathing and be okay for a while. Right? It's not like so bad that we're worried about they're going to go into cardiac arrest, in the next couple minutes if we don't intervene. Right? So the respiratory distress patient, they may be breathing maybe a little bit fast, right? Maybe just a little bit outside of normal. Right? They're complaining of some difficulty breathing, but the oxygen levels in their body are still good. They're not turning blue or anything like that. Right? That's us kind of saying, okay, everything's checking out, but I can see that you're having some trouble breathing. Right? We're doing okay. We're not happy that they're having some trouble breathing. Don't mistake me on that side. Right? But the quality of their breathing is good enough that it's not an immediate life threat. Respiratory failure is now they're still breathing, but they're not breathing adequately for life. So maybe that patient is breathing 4 times a minute in shallow. Well, they're still breathing, but nobody's going to survive on 4 breaths a minute in shallow for very long. So respiratory failure is it's no longer adequate for life. And then the last one is respiratory arrest. And respiratory arrest is now they're not breathing at all. Right? That's once they shift to the word arrest, not breathing at all. We can think about cardiac arrest. Right? They use that arrest word. Now the heart is not beating at all. Respiratory arrest is they're not breathing at all. Some people see respiratory failure and they think that that means that the patient's not breathing anymore. And again, they are still breathing in respiratory failure. They're just not breathing adequately for life. So they're breathing 8 times a minute and shallow, and they're turning blue, and they're altered. None of those things are good things. Right? Arrest, obviously now you're not breathing at all. That's a bad deal. So we got some options and pulled out kind of the main ones. There's other ones as well that we'll learn about and cover one day. But the initial ones, the most kind of commonly utilized and asked about ones. First one is a nasal cannula. Okay? Nasal cannula has the two little prongs on there that actually go into the nose. Right? That's the nasal, is into the nose. And so if you look at these, right, you can see the curvature of those prongs. Right? So they're curved back. That curve is going to go into the nose that way. Okay? So you're just going to put that in the nose, and then you're going to go around the ear, and you can kind of cinch it up underneath their chin just to help stabilize it in place a little bit. So on an oxygen tank, we can set our flow rate to 1 to 6 liters per minute. Pretty dang standardly is a little bit more in the 2 to 4 liters per minute. I know a lot of people, if they're going to use a nasal cannula, a lot of people might just go, let's try 4, or let's start with 2 and see how they do. Right? You can go up to 6. 6 typically becomes a little bit uncomfortable for the patient because it's a pretty high amount of oxygen pressure shooting through a couple tiny little things shoved into a person's nose. So just those right into the nostrils, and again around the ear, and then you can kind of cinch it up under the tongue with it connected to the oxygen tank. So 1 to 6 liters per minute will give you about 24 to 44% oxygen that the patient's going to breathe. So if you do the flow rate on 1 liter per minute, you're going to get the 24%. If you do it on the 6 liters per minute, you're going to get the 44%. And so that's kind of the range. It matches up with the amount of oxygen that we're delivering. And the reason why it's kind of low, weird numbers like that is remembering that room air, right, everything that we're sitting around breathing right now, room air is about 21% oxygen. The oxygen tank is 100% oxygen. So when this person has the nasal cannula in, they're breathing in still a lot of room air, that's 21% oxygen, and they're breathing in just from right there, 100% oxygen, because that's what's coming from the oxygen tank, right? So even though we're getting 100% oxygen from the tank, we're still breathing in so much just room regular air that it really kind of dilutes that oxygen percentage down, right? So they're getting just a little bit more than just room air breathing, right? 24 to 44% for nasal cannula. Okay. In the registry world, not too often is the answer to the question nasal cannula, right? We don't see that utilized quite as often. But in the real world, right, so to speak, real world versus registry world or textbook world, right? And in the registry world, we're not really going to be doing much in the way of nasal cannulas. In the real world, you might do them a lot more often, right? Or see people on them more often. So it's really for that patient, they're still breathing well, quite well on their own. We just need to supplement their oxygen just a little bit. That's why they'll call it supplemental oxygen. It says, you're breathing all right, let me just give you a little bit extra oxygen. You're breathing all right, but let me give you a little bit extra oxygen. More commonly in the registry world is moving over to your non-rebreather mask. Non-rebreather mask. Our flow rate from the oxygen tank on these are going to be 10 to 15 liters per minute. A lot of people will just say go straight to your 15 liters, high flow oxygen, right? So we can say 1 to 6 liters per minute through the nasal cannula, 15 liters per minute, 10 to 15 liters per minute through the non-rebreather. Okay? And so you have your registry skill sheet that makes sure you know how to use these well enough, but they'll give you up to 95% oxygen. Right, so quite a big jump up in the percentage of oxygen that the patient is going to be breathing out compared to our nasal cannula. On the nasal cannula 24 to 44, put a non-rebreather on, up to 95%. Right, 95%. And the reason why is because the vast majority of what they're breathing is just the oxygen coming from the tank. Right? So you can see there's little flaps that are on the outside here that cover up the holes that are really preventing any sort of room air from coming into the mask that the patient is going to breathe in. And we said that breathing into the room air is what diluted the nasal cannula percentage down to 24 to 44. So those cover up and prevent really any of that outside air coming in. So it's preventing us diluting down that 100% oxygen. And so they're getting pretty dang close to it. The reason why it's not quite 100% is these face masks don't create a perfect seal, right? So there's still going to be some amount of air, right? Some amount of room air that's going to work its way around the mask and come in, right? So it's pretty good, but it doesn't completely seal off the mouth, and it doesn't completely make sure that we're only getting the air coming from the oxygen tank, right? But it gets us pretty dang close. So these are for the patients, right? A little bit more commonly in the registry world. They're breathing okay enough, right? Their respiratory distress, right? Whoops, sorry about that. Right, respiratory distress, we can use nasal cannulas, non-rebreathers. Right, they're still breathing okay, but they definitely need more oxygen. Right, so that's where we said we're going to supplement that oxygen. We're going to administer supplemental oxygen. Right, the rate that they're breathing, the quality of their breathing is still okay, but they do need more oxygen. Right, so we can do nasal cannulas, or probably more commonly in class and tests and national registry is going to be using a non-rebreather. Once we shift over to, a BVM or doing a mouth to mask, right, where we're going to provide the ventilation, is now us saying, this person is no longer breathing adequately for life, so I need to take over for them. Right? Or in respiratory arrest, they're not breathing at all, so I need to breathe for them. Right? So the distress, they're still breathing okay, let me just supplement their oxygen. Respiratory failure or arrest, they're not breathing okay, so let me come along and breathe for them. Okay. So the bag valve mask is the BVM, okay, which is bag valve mask. Okay. We will set to 15 liters per minute, high flow oxygen. And this is saying we're going to get up to 100%, because now we actually have this face mask that we're really going to kind of press down on that patient's face, and we're going to prevent, right, the kind of pliability of that mask is going to really form a good face to mask seal, so that we're not going to actually pull in any sort of outside air. Right? If you don't quite have a good face to mask seal, then it may dip closer to like that 95% like a non-rebreather. Right? That's why it doesn't say it guarantees 100%. It says up to 100%. If you have a great face to mask seal, you get 100%. If you don't have a good face to mask seal and you're pulling in some of that room air, then you're not going to quite get 100%. Good. So BVM ventilation is that one. And we'll talk through our ventilation rates here in a second. And then mouth to mask, right, is usually if you get like a CPR pocket mask, right? And most of the CPR pocket masks that are designed for it, they'll actually have a port on it where you can hook your oxygen tubing from your oxygen tank on there. And so we're going to use our lungs, our body, to provide the force of that ventilation. And then we're going to supplement it with the oxygen coming from the oxygen tank. Right, that's best case for the mouth to mask. Right? They say it's preferred because you can generally get a better face to mask seal compared to even like a one person BVM. But more commonly for us, we're not going to do mouth to mask. We're going to get our BVM out and do it that way. So if it has that port for the oxygen, then we're going to hook it up, 15 liters per minute oxygen. And it says we'll get 55% roughly is what they'll get. Well, let's think about that. If we have a good face to mask seal and we're getting 100% oxygen from the oxygen tank, we're going to kind of step back and think about it. Why did that oxygen get diluted down to 55%? And it got diluted down by the rest of the air that we're providing. So if we just had that face to mask seal and the 100% oxygen, 100% oxygen would be the only thing going to that patient, right? But in mouth to mask, we have to breathe into it to actually deliver that oxygen and that air with enough force to get down into the lungs. So we have to breathe in, which means we're breathing out our exhaled air with the oxygen coming from the oxygen tank. And so when we mix our exhaled air with the oxygen tank 100%, it's going to come out to about 55%. Because remember, room air, we said that we're breathing in is about 21% oxygen. So that's the oxygen coming in. When we breathe out, we're not breathing out a lot of oxygen. So the amount that we're breathing out is obviously going to be even lower than the 21%. Right, so in mouth to mask, we're using our lungs and our diaphragm to provide the strength behind the breath. And then we're using the 100% oxygen from the oxygen tank to really help provide a good, high quality, high concentration of oxygen. So good numbers and good percentages. There's other ones. There's simple rebreathers and partial rebreathers. There's Venturi masks that have adapters, and all of those just manipulate, just how much oxygen do we want our patient to get? Because one thing that we'll learn over and over and over again in medicine is too much of a good thing always becomes a bad thing. Too much of a good thing becomes a bad thing. So oxygen is great. We all need it to stay alive. Too much oxygen can actually become a bad thing, but it takes a while to get there. And it's not a complication that we typically think too much about in the more short-term pre-hospital environment, right? But it is a very real thing that too much oxygen, it can actually cause hyperoxia or oxygen toxicity, right? So too much of a good thing becomes a bad thing over time. Key is it takes some time. All right, so assisting ventilations, we said inadequate for life was respiratory failure. If we said they're apneic, that means they're not breathing at all. So that's our respiratory arrest. And then this magic word right here, it was going to be your best friend if you remember it. Right? If a scenario question, if a multiple choice question ever describes to you shallow respirations, if it's a treatment-based question, your answer must include, we're going to ventilate the patient. We're going to assist ventilations. We're going to ventilate using a bag valve mask device. We're going to provide positive pressure ventilation. If they say shallow breathing, your answer must include positive pressure ventilations. You can't choose a non-rebreather. Because the idea is, if we're only breathing shallowly, we're not actually getting that air down into our lungs. Because we're breathing shallowly, we're only cycling it through what we call the dead space that we'll cover in anatomy and physiology. Right, so that's only being cycled through the dead space. So we're not actually able to get the oxygen down into the alveoli in the lungs where that oxygen will actually be able to get to the bloodstream. So if you see shallow, or other ways that they could tell you shallow would be minimal chest rise and fall. Minimal chest rise and fall is another way of saying shallow breathing. Right? But shallow breathing, your answer must include assisting ventilations if it's a treatment-based question. And a lot of those questions, two of the answers will be administer supplemental oxygen. And that phrasing, administer supplemental oxygen, is saying, like, we're going to use a non-rebreather. And then two of your answers typically say assist ventilations. So administer supplemental oxygen, those two are out right away. if you saw shallow respirations. And now we're down to 2 answers that say assist ventilations. And then we got to figure out what's better about one of those answers compared to the other one. Right? So such a critical thing, right? I can't encourage you enough from the test taking strategy standpoint of how do we get 4 potential answers down to maybe 2 potential answers. And then we can figure it out from there. Right? We're kind of playing process of elimination with it a little bit. So once we make that decision, they're not breathing adequately for life, or they're not breathing at all, they're breathing shallowly, we're going to assist ventilations. Then we have to make a determination of, well, how fast are we going to do assist ventilations? So our ventilation rates for an adult is 1 breath every 5 to 6 seconds. And this is when we just have something like an OPA in, we're just doing some BLS bagging, rescue breathing, not CPR. And CPR is different. We do our 30 chest compressions and then 2 ventilations. This is where the patient's heart is still breathing. We just need to ventilate them. Okay. So we're going to get what we call the CE grip. Right? The C, right, of your thumb and index finger. The C holds your mask. Right? The C holds your mask. The E is your remaining 3 fingers. And those 3 fingers help just lift the jaw up. Right? So it's the CE grip. Right? C for the mask, E for the jaw to help just kind of stabilize it and hold it onto the jaw there. So we're going to deliver 1 ventilation every 5 to 6 seconds. So it's actually quite slow when you think about it. If you're really counting it out and doing it, right, it's a pretty chill job that you've got. Now, what typically happens if we've got that critical patient there, we know the numbers in our head. Everybody's like, all right, you know, the adrenaline starts going, you start, ventilating too quickly, right? And you see it a lot. We see it a lot on National Registry skills testing, where we have our assisting ventilation station. And people are saying, okay, I'm going to ventilate 1 breath every 5 to 6 seconds, right? And they're verbalizing, they're telling us the correct answer, but then their actions aren't doing what their mouth is saying. So they're saying, I'm going to ventilate 1 breath every 5 to 6 seconds. And they're sitting there ventilating every second or every 2 or 3 seconds. Right? So it's 1, 2, 3, 4, 5. Squeeze. 1, 2, right? We got to think about it. We don't breathe that fast. So we shouldn't bag somebody so fast. Right? We shouldn't ventilate somebody so fast. The other thing, all of us breathing, we don't breathe in like this. We don't go every time we take a breath. Right? We take just a nice, gentle, slow breath. So we should deliver a nice, gentle breath to that patient, ventilation to that patient. So we're going to squeeze the bag over 1 second and then release. 1, 2, 3, 4, 5. Squeeze it over 1 second. 1, 2, right? And we're going to keep going that way. So ventilating over 1 second just until we see chest rise and fall, right? That's the key. That's how we determine if we ventilated enough. Right? We just until we see chest rise and fall. That's all we're shooting for anytime we're ventilating a patient. If I come along and intubate a patient, we're going to squeeze the bag just until we see chest rise and fall, right? That's how we make the determination to stop, where we say we've given them enough oxygen. So if it's only a half a squeeze of the bag and we see chest rise and fall, then guess what? A half a squeeze of the bag is all they need. Right? So adults, 1 breath every 5 to 6 seconds, which is 10 to 12 breaths per minute. Right? On the infant and child, it's 1 breath every 3 to 5 seconds. They're burning off their oxygen a lot faster, so we need to supplement it more quickly, right? More regularly. So we're going to do 1 breath every 3 to 5 seconds. We're still going to squeeze that bag over 1 second. 1, 2, 3. Squeeze. 1, 2, 3. So still delivering it over 1 second, still just looking for chest rise and fall. Okay. We're just going to do it a little bit more often, 1 breath every 3 to 5 seconds. which the math of those two come out to 12 to 20 breaths per minute, which we know that kids and infants breathe faster than adults do. So we should ventilate a kid and infant more quickly, more often than we do an adult. Cool. All right, so that's got a perfect little, almost right on an hour this morning. Thank you for hanging in there on this one. I hope it was helpful and beneficial, whether you're at the end of your program, just starting your program, in medic school, because we review all of the same stuff in paramedic school too. So hopefully it was a good review just to help continue to get some of those numbers out there. If it's been a little while since you've seen some of those numbers, then you really have to kind of review them regularly and make sure that we remember all the kind of highlights that we need to for it. So I hope, again, that this one was helpful today, and I will shoot everybody messages and let you know when I do more. Okay. Cool. All right, everybody. I will see you later. Right? Catch you next time. Bye.